Hello everyone, I am Dr. Monica. Today's video is about periodontal pocket. So what is periodontal pocket? It is defined as a pathologically deepened gingival sulcus around the tooth at the gingival margin. Coming to the classification of pocket, pocket can be broadly classified into gingival pocket and periodontal pocket. Gingival pocket, it occurs due to the gingival enlargement without any loss of tooth attachment. In this pocket is formed due to overgrowth of the gingiva rather than actual destruction of the underlying bone. Whereas periodontal pocket, which is true pocket, in this there is destruction of the periodontal ligament and alveolar bone, which leads to deepening of the gingival sulcus. Periodontal pocket, it can be further classified into suprabony, intrabony, simple, compound and complex. Suprabony pocket, in this the base of the pocket, it is above the alveolar bone, whereas in the intrabony we can see that the base of the pocket, it is below the alveolar bone level. So coming to the simple pocket, it involves only one tooth surface, whereas the compound, it involves two or more tooth surfaces. Whereas the complex, it has more complicated parts. Sometimes it extends between the roots. So the intrabony pocket, it is further classified into one wall, two wall, three wall osseous defect depending on the number of walls present. So one wall means only one wall is present, and in the two wall only two wall remains, and in the three wall osseous defect only three bony walls remain. That is, it is most favorable for the bone regeneration procedures. The further classification of infrabony and intrabony pockets, on the basis of number of walls remaining, we have one walled, two walled and three walled. Depending upon the depth and width of the underlying osseous defect, we have shallow and narrow, shallow and wide, deep and narrow, and deep and wide. Depending upon the nature of the soft tissue wall of the pocket, we have edematous and fibrotic. Depending upon the disease activity, we have active and inactive. Talking about the differences between suprabony and intrabony pocket. In suprabony pocket, the base is coronal to the level of alveolar bone, whereas in the intrabony pocket, the base is apical to the crest of alveolar bone. In suprabony pocket, there is horizontal pattern of bone destruction, whereas there is vertical bone destruction pattern in the intrabony pocket. In the suprabony pocket, interproximally, we can see that transeptal fibers, they are arranged horizontally in the space between the base of the pocket and alveolar bone. Whereas interproximally in intrabony pocket, transeptal fibers, they extend obliquely from cementum beneath base of the pocket along alveolar bone and over the crest to the cementum of the adjacent tooth. Coming to suprabony pocket, on facial and lingual surfaces, periodontal ligament fibers beneath the pocket, they follow their normal horizontal oblique course between the tooth and the bone. Whereas in the intrabony pocket, periodontal ligament fibers follow angular pattern of the adjacent bone, and they extend from cementum beneath the base of the pocket along the alveolar bone and over the crest to the join with the outer period. Coming to the clinical features of periodontal pocket. Gingival wall of the pocket presents with bluish red discoloration, which is caused by circulatory stagnation. Gingival wall also presents with flaccidity, that is caused by destruction of gingival fibers and the surrounding tissue. Gingival surface appears smooth and shiny, caused by atrophy of the epithelium and presence of edema. There is pitting of the gingiva on pressure application, which is also due to edema and degeneration of the intracellular elements. Sometimes gingival wall may appear pink and firm. In this is due to fibrotic changes predominating the exudative changes. Bleeding on probing is seen of the soft tissue wall of pocket due to the increased vascularity, thinning and degeneration of the epithelium. Periodontal pocket presents with pain in the inner aspect due to the presence of ulceration. Pus discharge can be seen on application of digital pressure due to the presence of inflammation of the inner wall of the pocket. So now let's understand the pathogenesis of periodontal pocket. The initial lesion in the development of periodontitis is inflammation of gingiva in response to a bacterial challenge. For the formation of pocket, the first change visible is in the junctional epithelium. So looking at the diagram of a normal gingiva, this is the tooth surface, this is the root, and this is the junctional epithelium. So the cells in the junctional epithelium, they proliferate along the root surface in a finger-like projection manner. After this, the coronal portion of the junctional epithelium that get detached from the root due to the presence of bacterial enzymes and the physical forces exerted by them. Whereas the apical portion of the junctional epithelium that migrates and it is later replaced by a pocket epithelium. Initially, there is presence of gram-positive bacteria in the supragingival plaque, and there is minor change in the color of marginal gingiva from coral pink to red. Later on, there is increase in the supragingival plaque and bacteria, which seeps into the gingival sulcus and results in increase in the subgingival plaque and bacteria. So, in the subgingival plaque, there is predominance of gram-negative bacteria. We can also see that junctional epithelium, it projects into the connective tissue in finger-like manner. So pocket formation, it starts as an inflammatory change in the connective tissue wall of the gingival sulcus. So the inflammatory exudate causes degeneration of the surrounding connective tissue, including the gingival fibers. So just apical to the junctional epithelium, the collagen fibers, they are destroyed by mechanisms like collagenases, which includes the MMPs, and fibroblasts also phagocytose the collagen fibers. We can see that the apical cells of the junction epithelium, they will proliferate along the root surface, whereas the coronal portion of the junction epithelium, they detach from the root surface. As a result of inflammation, PMNs invade the coronal end of the junction epithelium in increasing number, and when the relative volume of PMN reaches approximately 60% of the junction epithelium, tissue loses its cohesiveness and they get detached from the tooth surface. We can see that the sulcus bottom shifts apically and the oral sulcular epithelium occupies gradually increasing portion of the sulcular lining. So initial deepening of the pocket has been described as occurring between the junctional epithelium and the tooth or the intraepithelial cleavage within the junctional epithelium. As a result of phagocytic action of neutrophils and macrophage in the connective tissue, there is ulceration of the pocket epithelium, and the established periodontal pocket, we can see that there are signs of bone loss. Coming to the histopathology of lateral wall of periodontal pocket, most severe degenerative changes are seen in the lateral wall with the presence of epithelial buds or interlacing cords of epithelial cells which project from lateral wall into the adjacent inflamed connective tissue and extends apically than the junctional epithelium. So it is also densely infiltrated by leukocytes and edema from the inflamed connective tissue. The cells undergo vacuolar degeneration and after rupture, they form vesicles. The progressive degeneration and necrosis of the epithelium, it leads to ulceration of the lateral wall of the pocket, exposing the underlying inflamed connective tissue along with signs of suppuration. Coming to the soft tissue wall of pocket, the connective tissue, it is edematous, densely infiltrated with plasma cells, followed by lymphocytes and scattered PMNs are also present. It also exhibits varying degrees of degeneration with presence of single or multiple necrotic foci. There is proliferation of endothelial cells with newly formed capillaries, fibroblasts, and collagen fibers. The blood vessels, they are increased in number, dilated, and engorged, particularly in the subepithelial connective tissue layer. Periodontal pockets as healing lesions. Periodontal pockets, they are chronic inflammatory lesions constantly undergoing repair. Complete healing of pocket does not occur because of the persistence of the bacterial attack. The condition of the soft tissue wall of the pocket results from the interplay of the destructive and constructive tissue changes. If the inflammatory fluid and cellular exudate predominate, the pocket wall is going to be bluish red, soft, spongy, and friable with a smooth, shiny surface. At the clinical level, it is referred to as edematous pocket wall. But if there is relative predominance of newly formed connective tissue cells and fibers, the pocket wall is going to be more firm and pink, and clinically it is fibrotic pocket wall. Externally, the pocket appears pink and fibrotic despite inflammatory changes occurring internally. So contents of periodontal pocket are the debris of microorganisms, mainly rods, filaments and cocoids, enzymes, endotoxins, metabolic products, gingival fluid, salivary mucin, desquamated epithelial cells and leukocytes. Pus is a common feature of periodontal disease, but it is only a secondary sign. Presence of pus reflects the nature of the inflammatory changes in the pocket wall. Presence of pus, it's not an indication of the depth of pocket or severity of the destruction of the supporting tissues. We can see extensive pus formation in the shallow pockets, whereas in deep pockets there is little or no pus present. Root surface walls of periodontal pocket shows the presence of pathologic granules which represent areas of collagen degeneration. Bacterial products like endotoxins, they are detected in the cementum wall of the periodontal pocket. Coming to the surface morphology of the tooth wall, the following zones can be found in the bottom of a periodontal pocket. In the first zone, cementum is covered by calculus, followed by attached plaque which is found in the second zone. This is also known as plaque-free zone, and it covers calculus and extends apically from it. Third zone is zone of unattached plaque that surrounds the attached plaque and extends apically to it. Next comes the zone of attachment of junctional epithelium to the tooth surface. The last zone, it is a zone of semi-destroyed connective tissue fibers. In this, we can see partially lysed connective tissue fibers and intact connective tissue fibers. The area between the base of the pocket and alveolar bone. The distance between the apical extent of calculus and alveolar crest in human periodontal pocket is most constant, having mean length of 1.97 mm. The distance from attached plaque to bone is never less than 0.5 mm and never more than 2.7 mm. Coming to the detection of pocket, pockets can be detected with periodontal probe, and radiographic examinations are not used for its detection. Radiographs indicate only areas of bone loss where pockets may be suspected. They do not show pocket presence or depth of pocket. In a normal sulcus with long junctional epithelium, the probe penetrates about one-third to half the length of junctional epithelium, whereas in a periodontal pocket with short junctional epithelium, the probe penetrates beyond the apical end of the junctional epithelium. Coming to the treatment of periodontal pocket, pocket therapy can be done. Phase 1 therapy, in which scaling and root planing is done with re-evaluation made no less than 1 to 3 months up to 9 months, followed by surgical therapy to eliminate the pocket. But the effectiveness of this pocket therapy, it is based on complete elimination of calculus, plaque and disease cementum from the tooth surface. Please like and subscribe this channel.